Good afternoon. This is Mark Watt. We're just about to get underway with our webinar, and at this time I'd like to invite our presenters to enable their cameras so that the video tracking will pass to you when you are prepared to speak. This is Mark Watt, Senior Consultant with the Accelerating Change Transformation Team, and I will be moderating the session this afternoon. It is my pleasure to welcome you to the Alberta Medical Association Virtual Care webinar. We're thrilled that you're able to participate with us today in today's session, and I can see from our participant list that we have a lot of interest across the province. I also note that there is great interest in supporting community physicians with virtual care, and extend a warm welcome to today's participants who have this interest. We will be using the question and answer feature, and I'm so pleased that many of you have found it already. Where you are able to ask a question at any time by clicking the Q&A button from the webinar controls. If you are on a Windows device, this is located at the bottom of the screen. If you're connecting through an iPad, this button may be located at the top of your screen. The question and answer feature is being monitored by subject matter experts, including Dr. Chandra Thomas and Meg Lenny, whom have expertise in implementing virtual care. These people may respond directly to questions through the functionality. Questions not directly answered here will be asked to our presenters during the Q&A portion of the session, and we will provide a summary of questions and responses and post these to the website as soon as possible, including questions that we may not be able to answer during this session. During the presentation, you should be able to see the presentation as well as the speaker. Clicking on any of the tiles may change your display. Feel free to use the question and answer feature to ask any question about Zoom technology or for troubleshooting. Today, we will hear from Dr. Heidi Fell, family physician and Alberta Medical Association's informatics lead. Heidi, would you just say welcome to the crowd?
Hi, everybody. Thanks for joining today.
And we also have with us Dr. Brad Baylor, family physician, medical director for the Accelerating Change Transformation Team, and chair of Alberta's Primary Care Alliance. Brad, would you say hello?
Hi, everybody. Thanks for joining us today.
And also we have Norma Shipley, fees consultant with the Alberta Medical Association. Would you say good morning, good afternoon, Norma?
Hello, everyone. Thanks for joining us today.
Please note that the webinar that you're participating in is being recorded. By participating, you understand and consent to the webinar being made publicly available via a link on the AMA website for an undetermined length of time. By participating in the question and answer function, your name entered in the Zoom sign-in may be visible to other participants during the webinar and or in the recording. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and is a traditional meeting ground and home for many Indigenous peoples. So this webinar is being provided to offer advice and guidance on how to start using virtual care and enable you to care for your patients while minimizing the risk of exposure to your patients, your staff, and you during the COVID-19 pandemic. This webinar will cover topics such as impacts of COVID and introducing virtual care, what is known about Babylon, advice and guidance on the new billing codes, guidance on privacy during a public health emergency, advice and available resources to help get started with virtual care. We have allotted about 30 minutes to answer your questions about virtual care. And before we get started, I would like to turn it over to Vic Taylor, AED Corporate Affairs from the AMA for an opening remark.
Thank you very much, Mark. On behalf of the Alberta Medical Association, thank you for joining us on this inaugural information session on virtual care. We sincerely hope today's webinar is informative and helpful to you in caring for your patients. At the same time, we are anxious to hear from you as we begin to address your associated questions and concerns. Your input is also critically important to us as we consider other tools and supports that we can make available to you and your colleagues. And finally, and perhaps most importantly, a special thank you to the AMA Board of Directors for their support in arranging today's session. I am now pleased to turn things over to our first presenter, Dr. Heidi Fell.
Well, hello again, everybody. So we have all types of people on the webinar today. So I'm just going to start off with a couple of basics about virtual care. Anybody that's already living this might be a review for, but that's okay. So COVID has changed entirely how we provide care in our offices and our hospitals. The seminar today is about minimizing risk for patients, physicians, and staff, and virtual care really allows us to minimize those personal interactions and keep that social distancing going so we can help protect our vulnerable patients, our physicians, and our staff. Okay? It also works really well for physicians and patients in isolation so that we can maintain care for people without actually putting anybody at risk. Just as a reminder, continuity of care remains really important. So those relationships between physicians and patients are important, and other team members. And the CPSA standards are still in force, and it is up to us to try and provide care to the best of our ability to those standards that we can. Virtual care can be provided through either phone calls, messaging, or video. And I urge you, if you're not sure where to start with the phone. It is the simplest technology. It is secure. Patients are already familiar with how to use it, and so are we as care providers. So it doesn't have to be complicated, but we will talk lots about messaging and video as well. So just a word about the elephant in our virtual room today. I want to talk a little bit about Babylon. Okay? First off, I want to acknowledge the angst and anger and concern and anxiety that Babylon has produced in us. It really feels like medicine is under fire from all sorts of directions these days. And I want to acknowledge that the AMA has really heard these concerns, and we have been working hard for you in the background in terms of advocacy and clarification. Okay. So what are the issues with Babylon? A, it's not linked to the medical home. It doesn't help provide continuity of care. Patients can have their visit summary faxed to their family physician if they want, but that's not automatic. Two, it's a perceived threat. So A, it feels like competition to us at the moment because many doctors in the province, other than through Babylon, are also providing these virtual care services. And if we have an existing relationship with our patients, that's the best place for our patients to get that care. Also, there's questions around the fees, and I'm seeing tons of questions in the Q&A around fees already, and Norma will look at some of those. We've made some progress there, but I recognize that those might not fit the needs of absolutely everybody at this point. And there's also been concerns around the privatization of healthcare. Thirdly, there's been no AMA input into this whatsoever. We learned about this after the fact, after it had already been signed, in fact, from members texting us and sending us information about advertising that they were seeing. So the AMA didn't have any opportunity to provide guidance, advice, or input beforehand. And fourth, the timing, together with the COVID pandemic and the political environment that we're currently in, has been, I think, less than optimal, is safe to say. So what do we know about Babylon? So there have been some myths and various things going around. What we know is that the current contract is for 5 FTEs only, maximum. So they cannot exceed that without renegotiating with Alberta Health. Okay? It was an ARP as provided through the normal ARP process negotiated with Alberta Health. And they did start these negotiations before COVID or before February 20th. Okay, we don't know exactly when, but it was before those two events. The docs that provide services in Babylon, A, are our colleagues. So they are licensed within Alberta, and they're paid hourly, so with less than the usual sessional rate. The terms and conditions and privacy policy are Canada specific. So this means that some of the phrases you may have seen in the media about data being shared with foreign governments, For example, those clauses are not in the Canadian terms and conditions. I've reviewed them myself. Health data is kept on servers within Canada, and they have submitted a PIA, but it has not been yet reviewed by the OIPC because there's a one-year backlog at the OIPC right now. And I want to emphasize that this is standard practice within Alberta right now, unfortunately. Okay. What don't we know? So the AMA has no details on the exact amount that doctors are being paid, nor do we have exact details on the contract. Okay. However, what are we doing about this? Well, we can say that we've been advocating quite actively around this. You can see we've been voicing the concerns. There has been some movement on the fees issue, so there was some success there. We've been working to get answers and advocating for clear messaging. So for example, I've been in contact with Babylon myself a few times in the last week, including the Vice President of TELUS responsible for them. And TELUS has stopped all of their messaging and advertising to patients at this point in time. And they have also asked the government to stop providing any promotion on their behalf. Also, they have agreed that when they do resume advertising, they will be much clearer about encouraging patients to contact their family physician or their own doctor first before accessing the Babylon service. And they also agree that there is a need to advocate for virtual care tools and support for continuity of care for all physicians, not just now, but also after the pandemic. Okay? So we continue to work with them. We continue to hear your concerns, and we will continue to work to get clarification and also going forward to try and ensure that the AMA has more role in providing advice before these situations come up. So next slide, please. So at this point, I'd like to pass it over to Norma Shipley, and she's going to talk about what's hot on everybody's mind, which is the billing codes. Thanks, Norma.
Thanks very much, Heidi. Could I have the next slide, please? Thanks. So what I'll talk about today is a very high-level review of the new virtual care codes introduced by Alberta Health. And I must emphasize that this is what we know today about these codes. As that changes, we will try to post information and make sure there are billing corner updates for you. So just a quick high level, there are 7 new billing codes for virtual services during the pandemic. These are not subject to the daily cap that Alberta Health has announced for office visits March 31 forward. So they are not going to be included in that cap for you. They must be initiated by the patient. And so how do you do that? That would be a request for an appointment by the patient, a rescheduling of a previously scheduled appointment, a call from the patient with a problem, referral for consultation, or some part of your ongoing follow-up care, treatment, or other interaction that's related to an existing illness or condition of the patient. Alberta Health has been very clear, though, one of their big concerns is that physicians may not solicit the visit by cold calling your patients. The codes that they have introduced are very similar to their existing companion visit, consultation, and mental health service codes, but there are some differences, and those differences are just need a little bit of education and thought about. Could I have the next slide, please? So time and other requirements are different for these codes. Unlike your visits and the complex modifiers, you must only include direct physician-patient contact time in the time that you're accumulating toward these visits. These visits all have very specific individual time requirements. So the 0301 AD, that is the pandemic physician-to-patient interaction code, is 10 minutes or less. All the other codes that are specific visit codes, the 0303 CV, the 0303 FD, must be at least 10 minutes long. And the mental health codes have very specific time requirements that we'll talk about when we talk about them. When you're taking these calls, you need to specifically record your start and stop time in the patient record, and your patient record needs to be detailed. Alberta Health is very invested recently in reviewing patient charts when they're auditing. So it's important that you are documenting your start, your end time, as well as the discussion and the important points of that discussion in the patient record. Again, these codes need to be physician and patient direct interaction, and they need to be patient driven. Could I have the next slide, please? The premiums and modifiers that you would typically use for your visits and consultations are not available for these codes. So your CMGP and your complex modifiers for other visits cannot be applied to these codes at this time. Your business cost program and rural remote northern program payments also are not going to be part of the payment for these particular visits. There are also some limitations on billing these visits. You may claim only one of the virtual care or an in-person visit to the patient on the same day. No additional services can be claimed. I know that some of you have asked about a phone call with a patient earlier in the day, followed by an in-person visit later. And my advice to you when you do that would be to either claim the existing 0305JR for a phone call, followed by your in-person visit, or to accumulate the time as part of the time that you would use your CMGP or other modifiers for. And we can get into more specifics later on, or you can contact us more directly for questions if you have questions about that. The billing codes say that they are not for general information about COVID-19. And they're quite specific about that. If you are offering general information, you might want to consider using, again, the 0305JR. Could I have the next slide, please? So the specifics of the code, 03.01AD is for less than 10 minutes or 10 minutes exactly direct contact or email with the patient. So as you're having that discussion with the patient, keeping track of your time there would be important. As soon as you get to that 10-minute mark, I would, if you're having that phone or video conversation, shift to thinking that you were going to claim the 03.03CV, which is like a virtual 0303A. If you're emailing the patient, definitely then use the 0301AD. The 0303CV and the FV, which is for specialist virtual follow-ups, need to be 10 or more minutes of direct contact with the patient. Again, that can be by phone or video as it suits your practice and your individual situation. Could I have the next slide, please? The 0308CV is meant to replace the comprehensive consultation that any of you may claim in the, but remember that it still carries with it the consultation requirements of a referral and response back to the referring practitioner. It includes a comprehensive assessment in history, and again, you have to have spent at least 10 minutes or more in direct contact with the patient in order to claim this code. There's also a specific comprehensive consultation for psychiatry, and that is the 0819CX. For those who claim this code, the time divisions for this remain exactly the same as your 0819A, with the first 30 minutes being one call and the following 15 minutes or a greater portion thereafter, additional calls. And again, your direct contact requirement continues for both of these codes. Could I have the next slide? The 0819CW and CV are introduced for psychotherapy that would be provided as part of your general practice or for psychiatrists and generalists in mental health. These codes are meant for either psychotherapy, group therapy, family therapy, or other psychiatric services not elsewhere described. For the family medicine and pediatrics groups, Alberta Health has said that your time must be per full 15 minutes. So that means that you would need to spend 15 minutes in order to bill your first unit, 30 minutes in order to bill the second, 45 for the third, and so on. For psychiatrists, you would still use the 15 minutes or greater portion thereof. So at 15 minutes, you would be able to bill your first unit, at least 8 minutes into the second unit, your second, and so on. The patient in each of these cases must have an established history requiring this service. So I note in the Q&A that someone has asked about a referral to you for a patient who requires psychiatric consultation or ongoing psychotherapy. If the patient has an established diagnosis before that particular contact, you would be fine to use these codes. If you are making the diagnosis at that contact, I would say that if you're a psychiatrist receiving a consultation, that would be fine. If you are a family physician or a pediatrician, I would recommend your first contact where the diagnosis occurs be claimed using the appropriate other virtual code. And then for your next contact, go on and bill the 0819 CW. Could I have the next slide, please? So there are a lot of questions about effective dates of this service. The 0301 AD is active right now and can be used March 12 going forward. The remainder of the codes are being programmed by Alberta Health and can be claimed for dates March 17 going forward. Record your services, hold those records until you're notified that those codes have been activated. You'll see them in your EMR and then submit your claims for those services. And I'll pass back to Heidi now, who's going to talk about privacy.
So privacy in a public health emergency. So we still have privacy obligations, but things have changed and loosened up a little bit. So the CPSA and OIPC have both issued their own guidance, which is linked to on the AMA virtual care website. And I think there's going to be a link popped into the questions shortly if you want to look there. The deck and video will also be placed on that page later on too. So they've both said that it's critical to have ongoing awareness of privacy and security risks, but they agree that patient care and safety is the #1 priority right now during the pandemic, and short-term use of unregulated tools in emergency situations like now is acceptable. Okay? However, we must update the OIPC of any changes in practice. And Brad will talk a little bit later about unregulated versus regulated tools so that we have a better understanding of what that is. You do not need to do a PIA amendment formally before you start using these tools. You do need to email the OIPC, and that email again is linked to from our virtual care page. The OIPC is asking you to do 3 things. Tell them what you're doing, why you're doing it, i.e. caring for patients in a pandemic, and what things you have done to look after privacy and security concerns. Okay? We are working with the OIPC to try and make that easier for you to develop templates and things like that. And at this point, I'd like to thank Dr. Neil Hagan for his work with us in working with the OIPC on that front. You do not have to do a PIA amendment immediately. However, as time permits, and especially if you're going to continue to use that same tool after the pandemic, then you must do a PIA. Next slide, please. So just getting started on actually doing some virtual care, there are a few required elements. Okay? First of all, you need to have the patient's contact information. So you might want to get every contact with your staff to have them collect addresses, mobile numbers, ensuring phone numbers are correct, all that sort of thing. Second piece is that you've got to inform your patients so that you have a change in clinic processes, that you're doing things virtually and what those options might be. Third, you must confirm the patient identity. So that is easier if you're somebody like me with a closed panel that's known your patients for multiple years. I can recognize their voice over the phone and know it's them. But if you're doing a consultation, for example, and you've never met them, if you have video, it might be a good idea to ask them to show you their driver's license. If you're just on the phone, I've been asking them to confirm their date of birth and their current address and making sure that that jives with what we have in our records. Then you need to obtain patient consent. So this isn't really required over the phone because it's a secure communication. It's also not required if you have a fully secured solution like some of the regulated solutions are. But verbal consent is fine as at a minimum during this period of time. Though the CMPA, and again, these are linked to on our website, does have written documentation that you can look to. The CPSA has also provided some scripting information, and you can see that on our website too, but they suggest things that you should post on your website if you have one, things that you should read to the patient during the visit or before the visit, and things that you should document in your EMR record or your paper record. And then the last thing is that you do have to record all of these interactions in your legal record of care, so they somehow have to make it into either your paper chart or your EMR. So Brad, at this point, I will hand it over to you.
Thanks. So you guys have probably seen a lot about different tools that are in place, and the first distinction you want to make is this a regulated tool or unregulated tool? So the difference is regulated tools actually already meet the privacy and security requirements in Alberta and have a valid PIA in place. And if you go to the Alberta Medical Association website that talks about virtual care, we actually divide the tools into ones that are already regulated versus unregulated. You are allowed to use unregulated tools in urgent situations. And of course, this would count as an urgent situation. And so that's why you've seen so many tools that are being used by various practices and physicians right now. It is important to think about the consequence of using an unregulated tool now, and when this crisis does abate, can you continue to use that in a non-urgent situation? And I expect many of these tools will continue to apply for meeting privacy and security requirements, but we don't know, the timeline for that process. When you're picking a tool, there are a lot of considerations to think about. So the first thing is really think about clinic workflow and how it's going to fit into your practice environment. As Heidi talked about, phone is probably the easiest tool to build into your practice environment. Requires very little technological change aside from perhaps increasing the available phone lines in certain circumstances. Patients are familiar with phone, and you can do a lot over the phone. My clinic currently can provide around 50 to 60% of service via phone alone. There are also various secure messaging platforms, and there are, of course, the video conference technologies that you can use. And it's important to think about if you're layering on all these different types of solutions, so both phone appointments, secure messaging, and video conferencing, it can become quite cumbersome and difficult in terms of booking with your staff. So you want to think through what tools are going to give me the biggest ability to deliver virtually with the lowest level of disruption in my practice. You're also going to see there are standalone solutions versus solutions already integrated within your EMR. It is easier to use tools that are integrated within your EMR setting. Both Heidi and I actually use a secure messaging portal as part of our EMR. There are several EMRs that have integrated video conferencing abilities, and we expect actually TELUS to have integrated video conferencing very shortly for several of its products. The other thing to think about is who you're going to lean on for support. And so if you know physicians that are using various tools, or you have clinics within your social network, within your primary care network that are using tools, it'll be easier to rely on them for some advice on use and tips and tricks. Consider the ease of use both for physicians and your staff within your clinic setting and patients. Some are really robust solutions, but very complicated. Some are very simplistic to use. And so you really want to walk through what does this look like from a physician standpoint delivering the care? What does it look like for a staff member who's booking the care? And what might it look like on the patient side? Of course, in the crisis, the timed implementation, the wait list to be able to use these tools is an important consideration. And the cost to use them and the commitment, meaning how long am I committed to that cost for, also plays a big role. So think through how much is this going to cost me over what period of time? What am I committed to if I sign up to use one of these services now? If you're an AHS physician, Zoom has been provided for anyone with an AHS appointment or affiliation. We have the website or the web link in the presentation there. There is also information within the Connect Care manual that will give you more information on using Zoom. So that is an option for some of you who are currently appointed or hold an AHS appointment. We'll go to the next slide. So as you're getting started within your clinic, you want to think a little bit about processes, roles, and responsibilities within the clinic. And the first thing to think about are what are the tools I'm going to use? So are you using phone appointment? Are you using asynchronous messaging or secure messaging? Are you using video conferencing? Because all of those may be booked differently and managed differently from a workflow perspective. You also have to think about, am I a physician who's self-isolated working from home and I'm connecting through to a patient home? Or am I a physician in clinic connecting to a patient home, still seeing patients face-to-face? There are, of course, considerations in terms of how I might want to organize my day if I'm providing both virtual care and face-to-face care. And if I'm a physician working from home, one of the questions I saw coming through the chat was, if my assessment determines the patient requires a physical examination, how do I hand off care to one of my colleagues or a partner to perform that physical examination? And so you want to think about the workflow implications of that within your practice setting or amongst your partners. There's also the bit around who books these appointments and how do you determine how patient suitability for different types of appointments. And so there are different ways to do that. You can definitely look to enable your regular reception or admin staff to do that. That can be challenging for that group to be able to determine who's appropriate for a phone visit versus a video visit. As an example, some clinics might use staff with clinical backgrounds like LPNs or even experienced medical office assistants to try and assist with that triage. Other clinics have gone to physicians screening and triaging through a phone first type of arrangement where you might talk to all patients first and then determine if they need an in-person visit based on that phone assessment. I don't think there's any right or wrong to how you choose to do that, but you do want to have a really good protocol in your clinic. You want to communicate to your staff and your partners so that there's consistency in how that's being accomplished. Lastly, remember that technology, both for patients at home and physicians at home, as well as in the clinic, is something you need to consider. I work in a somewhat rural area, and rural Wi-Fi creates challenges with video visits at times. And even for myself, if I'm working from home, that can be a challenge. We always want to consider, are patients hard of hearing? Are they going to have problems with phone visits? Do they have a computer? Do they have an email address? Are the technologies there both for patient and provider to do this type of work? Heidi talked about tracking patient sign up and consenting. And as we talked about, virtual consent is good enough at this point in time. And how do you track that within a chart and make sure the consenting process has started? And that's something to consider. So in my practice, we've done some degree of virtual care for many years, so I'm lucky in that way. We do both telephone visits, we use a messaging platform through our EMR, and we have done virtual visits and expanded that for some point for the COVID crisis right now. And so we actually do block time specifically for phone and virtual appointments, and we have blocks of time that are for physical assessments. We have changed our workflow at the clinic, and I'll let Heidi elaborate on what she's done a little bit in a second, but we tend to see healthy patients requiring physical examinations in the morning, or high-risk people in the morning, and we see people that are sicker. We're concerned about illness symptoms. We need to consider how we isolate rooms at the end of the day once our work is done. And so you can consider how you block time for phone and virtual work, how you block time for messaging related work, and how you still see patients face to face when required throughout your day. In my clinic, because we've been doing it for a while, my reception staff is able to do the triage into these different types of appointments. But we have some flags where we might engage with the physicians if there's some determination needed on what the most appropriate type of visit would be. I think I'll hand it over to Heidi just to talk about what you guys have done in the last little while. Heidi.
Yeah, thanks, Brad. So in our clinic, we use Wolf EMR, and we had coincidentally just signed up for the patient portal before all this stuff started occurring, but we hadn't really started implementing it yet. We'd literally just gotten it set up for online booking and everything, and then we had to shut down the online booking because of all the COVID screening that's required for that ahead of time. So what we've done in our clinic is we've actually divided the physicians into 2 teams so that only half of us could be exposed at any one point in time if there's an exposure. We've done things like remove half the chairs from the waiting room. We don't have very many patients coming through. We do similar to Brad, where we do a virtual first type of visit. The vast majority of those are over the phone. And so we have our receptionists, when they're booking people in, tell them that they can expect a phone call at the scheduled time, and that it will probably be from a blocked number, because one of the things we've noticed is that all of our clinic lines are full, so we are having to use our own personal cell phones to make these calls. So just make sure that you shut off your caller ID, unless you want all your patients to have your phone number, which is up to you, before you start making these calls, and have your receptionist tell them that it'll come from a blocked number, otherwise they don't pick up. And that's why having them scheduled in for a certain time is helpful, because they know it's likely to be you. I've been doing most of the visits by the phone, and then those are generally satisfactory. I've had to change one over to a virtual visit, and that was the most tricky one, because I had to do the consenting piece for Zoom and things like that myself. Whereas when I know, so if it's for something like a rash or a skin concern or an eye concern where I need to look at their eye and I know it's going to need to be video, then I have my staff do a lot of the consenting piece and things like that, read them the script from the CPSA ahead of time for the visit, make sure that they have Zoom set up. I have an AHS login, so right now I'm using Zoom. That they have the Zoom set up at home, they know what number it is that they need to put in for the meeting, all of that kind of thing. And then what we're doing at the end of the visit is somebody's calling them back. So I tell them somebody's going to be calling you right back, and set them up for the patient portal, which then enables the secure messaging piece and also enables me to send documents to them. So if I need to send them a lab requisition or a x-ray form or something like that, so those are minimal these days, but I can do that. More lately, it's been forms and notes and stuff like that that patients need that I can send to them through the portal. And you can use any secure messaging solution for that. We screen everybody first. We tend to do all the virtual visits in the morning. The early afternoon, we have blocked off for people that have been screened and are not at substantial COVID risk. So we see them in the early afternoon. And then we have a 15-minute washout period. And then at the end of the day, we have slots for any patients that need to be seen because of concerns regarding COVID, or if they have any symptoms, or they're in isolation, or any of those kinds of things. And those patients, we actually have wait in their cars. We have a liquor store that's empty right next to us. And so we tell them to park in front of the liquor store, and we go out to them in our full PPE, and we give them hand sanitizer, mask and gloves, escort them into the clinic, do what we need to do, give them hand sanitizer and new gloves to leave, and then we doff our PPE. And so we've been finding so far that that process has been working fairly well. One of the biggest issues that we have is sometimes still patients don't pick up, or they're not there when you try to call them, and that happens occasionally, and we've just been rebooking those for another day because we tend to have quite a bit of availability right now. Different docs, not everybody in our clinic has AHS privileges, or well, they all have AHS privileges, but not everybody knows what their login information is. So they are using other tools as well. I have done a visit over text for somebody that was in a foreign country, so I needed to do it. They didn't have other stuff available. I did it over text. That was interesting and a new experience for me. And so other docs are using different tools within our clinic. We are hoping to be able to move to one integrated with our EMR within a couple of weeks, because as Brad alludes to, that makes it a lot easier to set it up and to get the patients to be able to use it easily. And then it will also be shortly, hopefully, a regulated provider as well, as instead of unregulated like Zoom is now. Okay, thanks, Brad. So just a closing comment about resources here. Again, we got the AMA Virtual Care website, and again, if we could have that address put into the chat, the Q&A box for people, please. So we have a toolkit there. There are links to the OIPC, CMPA, and CPSA resources, solution options, links to materials from the different vendors, links to stuff from other jurisdictions. So we've been talking lots with doctors of BC and doctors of Ontario. There's information regarding the billing codes, links to the fee navigator for those codes, links to the Connect Care virtual care stuff for AHS people and for the AHS Zoom, these webinar materials. And then we also have a COVID website, which has AHS materials, CMPA materials, and some business continuity materials. So there's a business continuity toolkit there from Ontario. And we are changing the website pretty much daily. So anything that we learn that's of great use, we try and put there. We're trying not to put everything there. We're trying to curate the collection for you so that it has some relevance for you. But we keep updating that, so please check back there regularly. Okay, next slide, please. Just in conclusion, before we go to the Q&A, I would really like to thank everybody for participating there. I hope you found this useful. This is a rapidly evolving scenario, as I'm sure you're well aware, and we're doing our best to learn the details as fast as we can. The AMA is here for you. We want to hear your feedback on this, what was useful, what isn't. We're more than happy to do additional webinars. For example, if we need a dedicated billing one, that is something that we could consider. And we want to continue to hear your concerns so that we can keep advocating for you. Some of what we do has to be kept behind closed doors for the time being, so please bear with us that you don't hear about everything that we're doing right at the time until certain things happen when we're allowed to share widely. But please know that we hear your concerns and we are working on them constantly. So thank you for coming. And at this point, I will pass it back over to Mark.
Thank you, Dr. Fellon, and thank you to our presenters. We'll now proceed into the question and answer portion of the webinar. Remember that you can continue to type in your questions at any time. This presentation is being recorded, and the question and answer that have been submitted will be posted to the website as well. So if you've missed something, you'll have an opportunity to pick it up there on the website later. Dr. Fell, Dr. Baylor, and Norma, maybe just as a opening salvo, I know you've been watching the chat, the question and answer box. Is there any question there that you'd like to jump in and just tackle right off the bat?
So one that I've seen commonly, and I'll actually ask Norma the answer to this, but I've seen several versions of the question of, so if I'm calling a patient back about abnormal lab results, can I use these codes? So Norma?
I would say that that depends a little bit on whether this is a call that you would typically have your team make and say to the patient, could you please come back in so we can discuss your results? If you're going to do that, if that would be a typical response to that result, then by all means, use these codes and, you know, keep track of your time, make sure you're conscious of how long that visit is and build the appropriate code. But don't forget, there also still is the 0305JR that can be claimed up to 14 times a week if you are calling a patient that you normally wouldn't ask to come in to discuss their test results. So you have that option, and I would let your previous practice guide you in this.
Great. Brad, has anything caught your eye in the questions?
I'm just going through right now, Mark. Maybe pass to Heidi for a moment. Continue.
All right. Well, we've got I think our highest voted question, so we'll start with that one then. The question is, how are we going to sustain our office operations if all we are able to do is virtual medicine that we can do from home and only deal with patients calling us in order to get paid? We have laid off more than half of our staff. This is a crisis. What do you suggest other than virtual care?
So that's one that we're all struggling with at the moment. I think, first of all, it's important to note that you can still book patients for virtual care. They don't have to call you. First of all, any of the normal interactions that they would have with you to book an appointment, you can book them in for virtual care. Frankly, the 10-minute issue with the 03.01AD is an issue. And so you have to look at how you're scheduling those, and remember that you have all of the other codes available to you, like the 0301NM from refills sent to you by the pharmacist, for example, consultations over the phone with colleagues if you're doing those, the in-person codes available to you for patients that you do see in person. I think there's no getting around the fact that this is a challenge and that this does provide challenges to our practices and how sustainable they are going forwards during this pandemic. And I'm afraid I don't have all the answers for that yet, though I do know we continue to advocate for better solutions for docs. Brad, any suggestions you have there?
Yeah, I mean, I don't know how much more I can add, Heidi, other than I think many clinics are in the same circumstance where they're having to lay off staff. There are, of course, both provincial and federal supports for being able to maintain staff or continue to pay staff. And one of the things AMA, I think, is working on is a document on those programs and how you might be able to access them to support your clinic. So stay tuned. We'll try and get that information as soon as we can to you. But it is shifting on a daily basis. New federal supports announced today. So more to come on that.
Great. I'll move us on to our next question. If a patient I saw in practice is screened COVID positive, does my clinic need to close? How do I clean the room differently due to the COVID context? Is the usual antiseptic process sufficient?
So I will try to take a stab at this one. I, like hopefully everybody here, is following the instructions of the medical officer of health. What I've seen so far is that usual cleaning processes are generally adequate, so that the usual surface cleaners, cavi wipes, something like that can do. We're having difficulty in our clinic getting enough of those, so we are using some spray solution that we have. And we have purchased some bleach because that is the backup. You can use a diluted bleach solution to clean. We have taken things off shelves in our clinics and put them in closed drawers and things like that. So there are fewer surfaces to wipe down in the clinic. And we are trying to not use the same room twice in a row for a patient that might be COVID positive. Regarding the contact, I think that the medical officer of health is better placed, regarding the contact and closing your office, I think the medical officer of health is better prepared to provide advice regarding that sort of scenario, but which is why we've taken the precautions in our clinic of dividing up clinic staff and doctors so that all of us can't be exposed by the same case. But I think the medical officer of health would probably assess each case on a case-by-case basis and provide you with individualized recommendations in those circumstances. Brad, have you heard anything different?
No, I think that's about the best answer that we could give right now, Heidi, and just continue to look for messaging that's changing daily on what you can do. But I think that's exactly what we're doing, Heidi, as well.
Great. I'll move us along now to a topic around privacy. And I guess as a great reminder, the questions and answers won't be placed up verbatim. We will synthesize them and make those anonymous. So if you are concerned about having your names associated with questions, when those are published, we'll have those removed. So the questions around privacy: what are the legal problems, implications of virtual care? And there's a couple follow-up questions here. Maybe I'll just to start with. Does Alberta have one platform? Will we ever? And how is confidentiality affected? I'll turn that over to you, Heidi, maybe as a first start.
Okay. So first off with this one, I think we want to emphasize that patient care comes first in a pandemic, and both the CPSA, the OIPC, and the CMPA do recognize that. So we have some protections there. The idea is that you do the best that you can in the circumstances, providing the best quality of care with the best security and privacy that you can do, and that's all that you can do. Confidentiality can become a concern if you're using virtual care. So, for example, things like these headphones have been invaluable because A, they allow me to type while I'm talking to the patient. Because another question that I've seen there, charting time is not included in these virtual care codes. There's the direct patient contact time. So A, it allows me to chart while I'm talking to the patient some. And B, it prevents everybody else in the room from hearing the patient's side of the conversation. They only hear mine, which is still a concern, but it's one that we can only do so much about because my cell phone doesn't work in a lot of my exam rooms due to the concrete building that I'm working in. So there is only so much that I can do about that. I do my best. We do try and spread out as much as we can to protect the confidentiality. We'd still have an obligation to do our best to protect that, but that's all we can do is our best.
So continuing on this, in this theme around privacy and tools, there's questions around how do I choose a tool? What tools are currently being used, and are you using tools currently? So Brad, Heidi, maybe some advice?
Brad, why don't you go first on this one?
Sure. So again, I would refer you to the AMA website. Virtual Care has a big list of tools that are available for use and currently in use. Question of how you pick a tool. So, and have I used? So I've used Medio in the past before. I've used something called React's app. I've used Doxy in the past before. I've used Zoom in the past before as well. I use the secure messaging platform through my EMR, which is Wolf portal. And in terms of how you pick, I think they all have pros and cons. That's the truth. The reason I've used so many is I like to try different things, and there's a balance between usability for the patient, usability for the staff, and usability for the physician. Some are more comprehensive. They can do more things. But with that comes the complexity of use. Some are simpler, but you sacrifice some of the complex integrations or complex tools that can be added onto it. So I think from my perspective, it's a personal choice. We'll pick a tool that works well for you, your staff, and patients, and you're comfortable with. Learn how to use it and go with it, and go from there. That would be my best advice, Heidi. I don't know if you want to add to that.
Yeah, I've used BrightSquid in my practice. We've recently started using the patient portal associated with my EMR because it's integrated. And I chose to use AHS Zoom because I have an AHS login. It was easy, and AHS has done some of the privacy and security work for me. So that was a big plus in my eyes. When something is available that is actually integrated with my EMR, that will probably be the tool that I use at that point in time. And assuming that we get the opportunity to continue using these tools post-pandemic, it will be important at that point to have something that is regulated, i.e. they have appropriate privacy and security compliance for Canada, including a PIA within Alberta. And so I think some of the integrated tools, as well as the AHS supported tools, will likely have the best chance of that going forward.
Yeah, and I can't emphasize enough that the more technology platforms we're using, the more complex it becomes and the harder it becomes workflow wise. So if you have something that you can access that's integrated, in my opinion, that works best. And if you're thinking about doing this for longer than the pandemic period, then look for something that's regulated or on the verge of regulated.
Great, and I guess maybe this question is for Heidi. In terms of the future, is there a vision in terms of one platform, or will we ever achieve a platform that works and is available across the province?
That's my dream. Will we ever get there? I think the answer is we probably won't all be using the exact same software platform unless we get to a period of time where Connect Care is used throughout the province. That's a government decision at this point in time. Short of that, though, I think what is more likely is that hopefully we will develop a system where one system can communicate with another system, and so that we have an ability to communicate between platforms rather than one single platform. Even that, though, is something we've been working before the pandemic, was something that we were working on a lot of background for. And there's a lot of complexity and detail to that will take some time to sort out, but absolutely that is my dream.
Thanks for that, Heidi. I'd just like to remind our participants that we are interested in hearing your feedback around what supports or tools that would be helpful for you. So if you wanted to add those to your question and answer, we will collate those as well. And that gives us really good feedback in terms of how to support our members the best. I'm going to move us along in our questions. We've had a question about strategies to keep virtual visits within the allotted time. Phone calls can run over. What strategies have you used, or which ones have been successful?
Yeah, I mean, for me, my experience has been no different than with in-person visits. Sometimes you have in-person visits and they run over or threaten to run over. And so as all family physicians do, you have to decide to balance your time as wisely as you can. And, how comfortable are you with being behind or not behind, same as you would do in office. So, I think you use the exact same tools that you would use in your office when you're on a virtual appointment with a patient or a phone call with a patient. If you feel like you just can't adequately explore an issue, you would potentially set up a follow-up visit for that. Make sure patients are aware that this is now how you're working, and you're booking your day in a similar fashion to how you would have booked it if it was face-to-face. But, I think rely on the tools you would use if you were in person would be my suggestion.
The other thing that I've found is that patients have actually been a lot more tolerant of me saying, okay, our time is up for today. I'm really trying to stay on time for other patients because they're expecting my phone call. Can I call you again on Monday, for example, and to discuss your third concern or whatever it is. And I've found that patients have been actually more receptive to that because they don't have to disrupt their lives in order to come see me. So they're in their home or they're at work anyway, they just have to answer the phone. So I have found that patients have actually been more receptive to those types of things than they are in person.
There's a question about around, I saw a couple of people came through the chat and also through the Q&A box, but my understanding is yes, you do need to record start time and end time, not just time spent. Norma, can you clarify that with us?
That's correct. The bulletin that Alberta Health has sent out is very specific in requiring 3 things: a detailed record of the communication with the patient, the start time, and the stop time. So I know that all of you typically would have a very detailed record. I would just pay attention to the level of detail, make sure that you're adequately capturing the conversation, the problem, the history, and so on. And then make sure when that call starts, note your start time. When it stops, note your end time. I have had people say that they are relying on the EMR for that. I would just caution you that in some EMRs, it is easier than others to extract that start time if there is a request for it in future. So better to, if you can, document that yourself in the record.
Norma, a follow-on question to that one. People have been asking if we need to record start and stop times for the 0301 ADs as well.
Yes, the bulletin is, I would say yes, the bulletin is not specific regarding that, but I would say to protect yourselves and make sure that you're not caught out if there is another bulletin saying, oh, by the way, you need to do this, just keep that as a practice for all of your virtual visits.
So that I don't forget, like I did several times the other day. Like, oh, right, I'm supposed to do that.
Great. We've got a question here regarding consents and how are consent requirements different for phone versus video? And what's the opportunity around staff helping you obtain consents?
So phone is a little bit easier because it doesn't require the formal explicit consent that video does. People understand how phone technology works. It's considered secure other than the risk of people in the room overhearing you, which is something to be aware of. And so it does not require the same detailed consent that video does. Video, the CPSA, I urge you to go to the website and actually pull up the CPSA document. There are exact quotes there of what the CPSA would like you to say to patients. And that gives a great opportunity that can be provided by your staff ahead of time, because they can simply read out the required verbiage from the CPSA document to the patient and get their consent ahead of time. And in fact, that's what we're doing in our office. If we have a reasonable idea, it's video ahead of time, we are doing that. The more challenging situation I've come into is where I'm on the phone and I realize, oh, I need to switch to video, and then I have to do it. But you could alternatively work that differently in that you could say, okay, well, let me call you back this afternoon. Let's do it by video. My staff will contact you and make sure that that's all set up ahead of time. That would be an alternate way that you can do that. So I would suggest really using your staff to do as much of that as you can, because the staff in our office are crying for things to do. We have the nurse manning the back printer where docs from home are printing off their prescriptions so that she can fax all those in because she's not dealing with the normal patient flow through the office. And the staff are actually looking for stuff to do. So we're using them to do that type of consenting and pre-work. They also do some of the COVID screening for us. If we have a patient that we need them to come in, we can pass them over to the staff. And not only do they book their time to come in, but then they have a script for the COVID screening questions that they can go through to make sure that there's no concern about travel history or COVID exposure or symptoms that I wasn't aware of. Brad, anything to add?
No, nothing else. That sounds good.
So we'll move into some clinical questions. Are well child checks, where they call the parents to book, i.e. the baby's due for a 2-month check, are those patient driven or are those physician driven?
Yeah, for me, there's a lot of these questions, and I'll defer to Norma. But what I'm going to say is, with all these, I think it's important to consider what is your usual process of care. And Norma, I don't know if you would agree with that, but that's kind of how I always have been framing this discussion.
I would agree with that, Brad. So if you would typically in your practice call that mom to bring the baby in for that 2-month check, continue your practice and make sure that you have documentation that would show that is your existing and current practice. You are continuing that. Because to me, I would see that as part of your follow-on or follow-up care of that patient. The cold call, and I've seen a couple of questions about cold calling. Alberta Health was what their stated concern, and I would ask people's indulgence, this is not my concern, this is Alberta Health. So what they stated was they were concerned that physicians would sit down and start calling all the patients in their practice with a question about how they were doing in this environment. So I know that you are all busy and you probably would not have time or capacity to do that, but that was the stated concern. So if you're continuing your current practice, continue your practice, make sure you have clinic policies or something that show that's your practice. And then just don't sit down and call a bunch of your, for example, vulnerable patients to ask how they're doing. Although, you know, as someone who has an elderly parent, I would appreciate if someone did that because it would show a lot of caring.
However, if you did have a process where you followed up patients after they were discharged from hospital, for example, and that was a part of your normal practice, Norma, it would be okay to continue doing that to check up on how they were doing post-hospital discharge, for example.
Oh, exactly, Heidi. If you know, if that's your typical practice, I would say that would be fine to continue that.
All right, I'll move us along into our next question. Is there any advice or direction around workers' compensation benefits, billings, and visits and forms for virtual care?
We have not to date had that conversation with them. They typically follow Alberta Health's fee codes, so I would expect shortly to see that they have implemented the virtual care codes. We will talk to them about these codes. I have to admit that we've been a little bit taken up with trying to clarify things with Alberta Health and haven't yet moved to WCB, but we will do that, and we will publish on the AMA Fee Navigator what the results of that are.
Thanks, Norma. Another question on the codes, and maybe it's a bit of a crystal ball. The question is, will these codes continue post-pandemic?
My crystal ball isn't that great, but Alberta Health has been very specific in its communication that in their minds, these codes are for the duration of the pandemic or until the Chief Alberta Medical Officer of Health, Dr. Hinshaw, indicates that they should be rescinded. So I think at this point, that's where they are. But I would say that, you know, as this evolves, this may change.
I would just add to that we will continue to advocate for that patients are going to demand this type of virtual care still be an option for them after the pandemic is over. And so we will continue to advocate for doctors to be able to reasonably continue to provide some extent of that care afterwards. You know, as you know, we don't have an existing contract with the government currently, and so those decisions ultimately are theirs to make, but the AMA will push for that as a need of our physicians and to look after our patients. Norma, I'm seeing a lot of questions about the diagnostic code for the virtual care bills, the 079.8 or 079.82. billing codes. Could you please clarify if those are required on all of those virtual care codes?
They are not. If you are claiming 03.01 AD, one of your diagnostic codes for that claim must be the 079.8 or 82 as accepted by your EMR. For the other codes though, of course, use the COVID-19 diagnosis if that is part of the reason for your call. Otherwise, use the appropriate diagnostic code for the visit itself.
So just one thing I'm seeing, Heidi, was the question around the PIA amendment and the messaging to the OIPC. Does every physician have to do that independently, or can the clinic do it together? And it kind of depends, I think, on how your initial PIA is set up. And maybe I'll hand that one to you just to clarify from your knowledge.
Yeah, sure. Certainly a PIA and a group practice can be submitted by a lead person on behalf of all of the custodians in the clinic. I haven't asked that question of the OIPC specifically. I will next week on our call, but I can't imagine it would be any different at this point in time. So each custodian does have the legislated mandate to provide this type of information. But if everybody in a clinic is doing the same thing from a practical perspective, I don't see any reason why you couldn't list your clinic, all of the doctors that are working there, and then answer the questions about what you're doing, why, and what safety precautions are you taking. I can't see that that would be an issue to do it as a group, as long as the individual custodians are all named in that email.
I've got a bit of a long question here, so so bear with me. It seems that there's a bit of concern that once the pandemic is over, there will be a sudden increased inflow to the clinic, and unsure if that time if the cap might impact us. And it's a bit of a crystal ball, so maybe help provide some context or any early advice around managing that increased inflow once the pandemic is cleared, and helping to mitigate any potential daily cap.
As far as we know right now, Alberta Health has no plans to back away from their other consultation proposals than the complex modifiers. We do continue to discuss with them. In fact, I know that Dr. Molnar is meeting with the minister sometime today to discuss that. But I would say that that is a potential issue, and I would encourage people, as you are thinking about your visits and phone calls, to remember that both your visits, your phone calls, and other things are part of that cap. We can help you with the specifics of which codes those are, but I do not foresee that those codes that cap is in the short term going to be removed. One thing I recommend to people is make sure on a day when you're getting close to that cap that you're billing all of your higher value services for that week as part of that week's submission. Hold on to your phone calls and your lower paid services until the next week. So if you're taking that hit of 50% on some of those codes, you're not taking it on your higher value services.
I also suspect that the pandemic restrictions will not be released all at once. I suspect that this will be more of a gradual process, and so I'm hoping that that provides some smoothness to how we ramp up again, as opposed to all of a sudden being slammed on week one. But my crystal ball doesn't go that far ahead, I'm afraid.
So there's a couple other questions that are recurrent. So one was around managing long-term care patients or nursing home patients, and do you do that in person or do you do that virtual? I haven't seen a lot of super concise advice on this. My group does look after the lodge in a long-term care facility in town here. Our biggest concern is actually that us as physicians may introduce the COVID as a vector into the facility. So we're actually trying to do as much of that care as we can virtually. And that's the best solution that we've come up with so far for that. But I think it's really an individual discretion on how you manage those patients who are in those types of facilities. I've heard other groups that are appointing one physician to be the long-term care person who will not be doing other work or in other high-risk areas. I think it's just about trying to minimize your risk to patients as much as you can.
Oh, thank you. I see that we're right at time. We have a lot of questions that still remain unanswered, and know that there's a commitment to getting answers to those as soon as possible. I did want to also note that there is some concerns that are being expressed through the question box. So as example, some concerns around AHS ambulatory clinics and physicians being instructed to remain at home and then being unable to fulfill their CPSA obligations. So I think we've noted these, but really I think at this point we're going to need to move ahead and close our session today. Great, I'll invite all of our presenters to come off of mute. And we'll proceed to responding to the questions that you've been entering. But as a reminder, feel free to continue to type in your questions at any time. As a reminder, this presentation is being recorded and the questions and answers will be available on the website. They will be anonymized, so your name won't appear directly beside a question. We will synthesize that and put them up on the website. I am seeing a common thread around what constitutes a generalist in mental health. Generalist in mental health, does that include a family doctor who does a lot of mental health and counseling?
Yeah, I mean, we can ask Norm to weigh in, but a generalist in mental health is actually a designation that's given to a physician. My understanding is they're mostly physicians who may have been foreign trained that don't have an FRCP. And you actually have to have that designation attached to your profile to be able to bill that code. So a family physician that's simply doing a lot of mental health related care, I do not believe is considered a generalist in mental health. Norma, is that correct?
That is correct, Brad. Typically, these physicians are working in AHS mental health clinics or in one of the facilities. And yes, you're right, often they are international grads who have either not written or not don't have the appropriate licensure requirements to be licensed as a specialist. They're still working here, they're still paid to work here, but they cannot claim as a specialist physician, so they have a specific designation.
Great. I'll move to another question, which is really focused around the regulated tools. Do physicians need PIA amendments even for regulated tools? And how could I tell if a tool is regulated?
So yes, physicians will eventually need PIA amendments for all new medical documentation practices that they have. You don't need to do it before you start for the pandemic situation only. A regulated tool is something that has a current, so it has all the proper privacy and security, and it has a current PIA associated with it in Alberta. That also still means that your clinic will eventually have to do a PIA with it. If you look on the AMA website, we have examples of regulated versus unregulated tools there that can help you decide whether yours is regulated or not as well. Though not all tools are listed there because there are many, many virtual care tools that are popping up as startups during this environment, and we can't possibly know about all of them. So you may not see the particular one you're looking for there. You can send us an email if you want to ask us if we know anything about it, but we may or may not.
So maybe a follow-up here, Dr. Fell. If the OIPC is backed up for a year, what's the hurry? And do we need to let the OIPC know if we're using the phone for virtual care?
No, assuming that the phone is covered in your current PIA, which I would imagine that it is because everybody uses the phone, you do not have to change it if you're just using phone. Okay. Why do we have to do a PIA? Well, because it's the law is really the answer, and it is required of every custodian within Alberta to have a valid PIA. And the OIPC themselves don't have the ability to say, no, you don't need a PIA just because it's a pandemic. They have said, okay, we'll take it a little bit easier on you, but legally they can't say, no, you don't need one. There's no real rush to get your official PIA amendment in, so you can do that as your plans to use what technology solidify, as you know what you might continue to do after the pandemic, and as you have time, given the crunch that most of us are feeling right now related to caring for our patients with COVID.
So just a couple questions, Heidi. The PIA is Privacy Impact Assessment, and OIPC is the Office of Information and Privacy. And so some people are asking if they're now doing virtual care phone visits from home, Heidi, and they may have had in their PIA, doing phone visits or virtual visits at their clinic previously. Does that require an amendment?
That is a really good question. I don't suspect that it does, as long as some remote access was included in your previous PIA. If there was no remote access or work provisions in your prior PIA, you might have to. That's a question that I will clarify with somebody from the Privacy Commissioner's office next week when I'm speaking with them.
That's my understanding as well, Heidi, that if you had remote access included, it would be covered, but we can get an answer back to everybody about that. There was just a few questions about that came in.
Great. Heidi, maybe we want to just follow up on the COVID workflow process. And we had a comment that that if patients were at risk for COVID with some symptoms of COVID, they should not come into a medical clinic. Can you clarify?
So in order to minimize contact between people who might be infected with COVID and people who aren't infected with COVID, we all are ultimately following the wonderful Dr. Dina Hinshaw's advice, the medical officer of health. And her current advice is if you can manage that patient without seeing them and you think they have COVID, you should manage them on the phone. The majority of patients with COVID can be managed without being physically seen because they just need to be checked that they aren't having substantial respiratory distress, which you can tell by talking to them, and things like that. If they do need to be seen, it depends on the situation that your clinic finds itself in with respect to PPE and the ability to keep that patient safe. If you don't have appropriate PPE in your office and you can't look after that patient, do not see them. You can refer them to 811. So if they do the health assessment, but if they have substantial symptoms that need to be seen and assessed and you aren't capable of doing it, either because you're on isolation yourself or because you don't have PPE or your office is closed, you're on vacation, et cetera, they can refer themselves, they can go through 811 and be seen that way. If you think that for some reason they're better off seeing you rather than going through 811, as far as I know, that is still up to your judgment as long as you have the ability to take care of them. Brad, that agree with your knowledge?
Yeah, exactly. It really depends on your clinic capability and whether you feel like you have the ability to protect yourself and and your staff and do that assessment or not. So bang on, Heidi.
So we'll stay in the clinical vein for a moment. And how do you handle situations where you may need things like vital signs, et cetera, as part of your clinical visit, or a patient has a complaint such as a genital rash or some other situation where you would have typically seen them in the office? How would you handle things like that?
So I've done a couple of video visits for rashes already. They've worked okay. Sometimes it's a little bit difficult to get that rash exactly in focus and takes a bit of doing. But I have been able to diagnose the two that I had that I've seen so far. If I wasn't able to, depending on, I would have to make a judgment call about the urgency and severity of their symptomatology and decide if I wanted to bring them in for an in-person visit or not, and also their COVID risk factors. Sorry, Mark, what was the other part of that question?
Yeah, but if it was in a sensitive area, i.e. growing, etc.
Yeah.
Right. Go ahead, Brett.
Well, I was going to say, I think historically we can manage about 75% of rashes virtually. There are 25% you just can't get a good enough look at it. If it's in a sensitive area, then again, I think it's up to the discretion of you as the clinician, the patient themselves, and the consent that they've given you, and their understanding of the platform that you're working on. So yes, I have had patients that virtually show me rashes in sensitive places or things in sensitive places, but only after we fully explain, the security of what we're doing, and they are consented and they have full understanding.
Regarding the vital signs, which was the other part of the question, blood pressure, often the patients have a blood pressure cuff at home. Otherwise, it's very difficult to do. Respiratory rate, you can tell a little bit through the talking. There's also something that I saw called the Ross test, which basically you ask the patient to take a deep breath as they can, and in their native language, count from 1 to 30 as fast as they can, and you measure how far they get and how long it takes them before they can get a breath. And I can't remember the exact cutoffs for those, but if they can only get to 5, for example, before they have to take a breath, that's a reasonably reliable indicator of oxygen desaturation and would change your management that way. Pulse, I've asked patients to see if they can find it and count it for me. Brad, I don't know if you have any other tips.
Yeah. I mean, many people also have things like, smart watches and other ways they've recorded their heart rate. There are some tools and apps and watches that attempt to give you an O2 sat, although they're not really great, in my opinion. You can do things like have a patient show you swelling, have the patient or family member, gently press to see if there's something like pitting edema. You can have patients and family assess for warmth of a joint. There are many things you can do virtually if you get creative about it. There's also a cutoff where you just have to acknowledge, I cannot do a good enough assessment without seeing this patient for real in person. And that's when you have to, make that call and say, actually, I need you to come in, or we need to get you somewhere where you can be physically assessed, because I cannot make a determination around what's going on virtually.
Great, we'll move on to the next question. But before we do, I also wanted to encourage participants. As mentioned by Dr. Fell, we are very interested in understanding what your needs are. So do please feel free to use the question and answer box to identify things that would help you manage the situation going forward. So please help us help you. And then on to the next question. What is the alternative to sending our administrative staff home? What roles can they play? And can you be specific about some of the options that you have used or seen others use? Are they working from home, or are they coming into the office?
Yeah, so we've had some administrative staff and nursing staff on self-isolation, either related to travel or exposure. Those staff have been able to work from home, and much of there's a lot of administration work in an office that can be done, remotely or from home if you have remote access to the system. And so, I think it's about, getting creative on how you use people. As an example, if you're seeing less people face to face and you have medical office assistants or admin positions that would typically be helping with patient flow, through the office, you can have those people sit with you during your video visit. They can help transcribe information. They can help create requisitions. They can help start letters, they can book follow-up appointments, they can scribe for you during your video visit. There are many things that those staff can do to aid with the flow of doing work virtually and speed up your process or help you with the process, as well. So those are just some examples of how we view staff differently, both in person and at home.
So there's also a few non-clinical type things that staff could do. For example, our staff cleaned out our storage room. First of all, we needed it as a place to put on our PPE because we had limited storage facilities, but they cleaned up our storage room, and lo and behold, they found some N95 masks in my size left over from the H1N1 epidemic buried in there somewhere. So, you can think of non-clinical things like that. We also had them go through all of our sample cupboards and all of our supplies to ensure that they were all up to date and not expired. So some of those maintenance type things in a clinic that might not get done as often as you would like, it's a perfect opportunity. Change some of the light bulbs in your waiting room. Give everything a nice deep clean. Some of those things. And you might want to think about if any of you have gone through a CPSA group practice review. There are lots of those standards-based things that you can use this as an opportunity to get caught up on. As well, if you have staff that are looking for things to do.
Great, thank you. I've had a question regarding how do you keep track of time for billing, and some recommendations on how to do that well.
Well, I just write down my start time and then my stop time right in my visit note. Occasionally I use Wolf, and there's fairly decent start and stop times in there. So occasionally I have to sort of go back and look, when did I start this visit, that way. I've also used, since I've been using my cell phone for calls, it keeps a record of how long I've been on the phone with that particular patient as well. So I've used that a few times when I've forgotten to record my start time. It's like, oh, I've been on for 12 minutes. Okay. And I know it's 9:32 now, so I must have started at 9:20. So I've done things like that. Brad or Norma, any other clues?
I would say writing down is your best option, or making it part of your electronic entry. I just can't stress enough how important it is to make sure you have that start and stop time very specifically recorded.
Norma, just looking at some of the questions around referral to specialty and specialty provision of care. And so just kind of a few themes bucketed together. So, can I still call patients if I have referral letters coming in to me for new consultations? Can I call them and set that up virtually and bill for it? Are the specialty consult codes specific to a specialty, or do they apply to all specialties, notwithstanding the mental health codes that you talked about? But if we're talking about consultation codes, could you just reassure us regarding those two things?
Sure. So definitely, if you receive a referral for a particular patient, contacting them to set up the appointment would not be considered, or should not be considered, you initiating that visit. That is part of your normal course of action when you get that referral. In terms of who can bill for particular services under the 0308 CV, the consultation, if you are a specialist who uses the 0308A consultation, or you're a family physician with special skills who uses the 0308A, you would, subject to the 10-minute requirement and a referral from another physician, be able to use the 0308 CV. If you're a psychiatrist, I'd really recommend the psychiatry consultation code rather than the 0308A.
Great. I'll throw another question at the panelist in relation to the patient side of the virtual visit. Is there any advice or guidance on confirming if the patient is recording the virtual visit, or having chaperones in video conferences and the documentations associated with such?
Good question on the chaperone front. I'm actually not sure how to answer that one. Brad, do you have any ideas?
So if it's something in my clinic that I would have had a chaperone in for, I have a chaperone for the video visit, Heidi. That's just the same standard of care, really, I think is the best way to consider that.
Regarding patients recording, in most of the tools, it is only the host of the meeting that can choose to record it if recording is offered at all. However, there is no way to prevent a patient from also turning on their phone voice recorder, same as they could possibly do that in your clinic as well. And that is something that the CMPA has sort of told us all to be on the lookout for in the past, not related to virtual care, but in terms of regular in-person care as well. And in some settings, such as cancer patients within AHS, they're actually encouraged to use a specific app that they have set up for that purpose to record the conversations if they want to. So there is nothing really legal or illegal about a patient recording a conversation, though common practice would be that they should inform you of that, but there's really no way to stop them if they're going to do it.
Norma, just a question around pharmacy codes. There's the 0301NM, which is communication with a pharmacy, and that can be phone or via electronic means for sure. A common question is around, well, what about those requests for refills? And when is that okay to bill for, and when is it not okay to bill for? And it is a gray zone, so I'd like your expert opinion on that.
So that is a tough one, and it's a tough one whether you're doing an in-person visit with the patient later or in the current situation. We recommend that you not use that code for refills longer than 2 weeks, and my understanding is that that was a convention that was agreed to by Alberta Health at the time that code was put in the schedule. So if in the current situation, if you get a request for a longer term renewal, what you could do is follow the same process that we recommend you do when you're seeing patients in person. Agree to renew for up to 2 weeks. Ask the pharmacy to please have the patient contact you, and then have a visit either in person or virtual with the patient to assess them and renew that prescription for a longer period of time.
Are there any tips for pediatric patients, and do you do anything different for some populations as it relates to virtual care?
Brad, why don't you take this one?
Yeah, I mean, so pediatric patients do pose a challenge, and sometimes you can have the parent of the patient assist you, with some measure of examination. I find it is harder the smaller the pediatric population we're talking about. So, yeah, very difficult for me to do a 1 week checkup, or a 2 week checkup, virtually. If we're talking more about, a 1 year review or an 18-month review, there are a lot of things you could do virtually in terms of, assessing developmental status, getting a good general a picture of how the child is doing. But I think if there's specific complaints, you're very likely to require an examination. And so it does pose a bit of a challenge. The same challenge actually had in some of the very elderly patients that have an acute concern or a new concern. Sometimes it's very hard to get them positioned okay, really reassure yourself that things are all right without a physical examination component. So, we do some well child checkups and child reviews virtually, but there is also many we have to convert to in person because we can't reassure ourselves without a physical examination.
There's a question here about residency, and people would like some advice around are they able to bill if they are themselves outside of the province of Alberta, or perhaps if the patients are temporarily out of the province of Alberta. Can you provide some guidance on that?
So this one, I would best recommend that they, for the legal questions around that, I would best recommend that they go to the CMPA links on the AMA virtual care page, because they do answer those questions. In most cases, if this is a patient that's part of your panel and happens to be traveling, as long as the legal action is brought in Canada, the CMPA would help protect you because it's the right thing to do to take care of your patient outside of the country. If you're soliciting business from outside of the country, that is an entirely different scenario. And so I would just suggest that you have a look at the CMPA link on our website about that. Regarding billing, Norma, I'll hand that over to you.
Thanks, Heidi. So in terms of billing, we have asked Alberta Health to give us an opinion about whether physicians may claim these services for patients who are not Alberta residents. We're waiting for a response on that. The issue there is that there is only a limited number of services that may be claimed for patients from outside the province, and this may not be part of that group. We've asked them to comment, and we can post our answer as part of FAQs. In terms of physicians from outside the province providing services to their patients, if you are providing services to a patient population that you would typically care for, I think that would be fine. Again, we've asked the question of Alberta Health, and we can post that answer.
Thanks, Norma. I've got a question here. With more community spread of COVID, are there any province-wide directions or specific directions for preventing spread in community clinics? Based on my own clinic of multiple family docs, there are some that are continuing to see routine visits and physicals, and others who have converted completely to remote care. Obviously, there is higher safety but lower financial benefits to virtual care. Is this currently left to each physician and patient's comfort level and judgment?
So all of us, again, we follow Dr. Dina Hinshaw's advice and the medical officer of health. I have not seen anything that very specifically addresses that particular question as of yet. However, I have seen stuff that suggests that physical distancing be implemented within clinics as well as much as possible. And just today, just before this announcement, they have essentially closed all massage services, chiropractors, naturopaths, physiotherapists, except for emergent and urgent treatment. So I think that sends a message about what the general expectations around society and people who care for people with physical means are. I haven't seen anything specific. One other thing that I'd like to mention that I forgot to mention earlier about our clinic is that we've also divided the staff and physicians into teams, so that we have 2 teams of physicians, for example, so that not all of us are ever in the clinic at the same time. And if there was a COVID spreading situation within our clinic, only half of our clinic would be personnel anyway would be exposed. And at that point in time, we would take the directions of the medical officer of health as to what we needed to do regarding cleaning, environmental cleaning, and any closures or staff rearrangement. Brad, anything you wanted to add to that?
Yeah, no, I haven't seen anything specifically. It's a tough call, right? If you close your doors specifically, there are patients who are going to need examinations. You increase their risk by forcing them to go to emergency facilities when maybe it could have been done in your family practice. Or are you in a situation where due to your location, due to the degree of outbreak, you actually think it's unsafe to do so. So I think that's why they're not going to make a specific stance. They're going to leave the principles there and allow clinicians to decide.
Great, thanks, Brad.
I just was wondering, Norma, there was some questions about looking after patients in long-term care or senior care facilities or senior homes. And, you know, to my knowledge, there is no specific codes for this. And yes, a lot of the codes are, you know, time-based or have complexity modifiers in a, you know, a supportive care environment as an example. To my knowledge, we have no specific tools other than the regular tools in place. But I don't know, Norma, if you have a different take on that.
You're absolutely correct, Brad. And, you know, I think that that is something that we will raise with Alberta Health is ability to care for these patients, particularly when one of the facilities is on an isolation. The current virtual visits require that direct contact between the physician and the patient. And I would advise everyone right now, unless there is that direct contact, either in person, so you are in person going to the facility, or you are having virtual contact that is by phone or video conference with that patient that you not claim for your services. Keep track of them though, so that if we are able to help Alberta Health see that that would be a necessary service, then you can make those claims.
I've got a question here to help support some of our community specialists on the line. Any advice around pre-scheduled follow-up appointments and new referrals? Can they bill in terms of outreaching to those patients?
So I think we've partly answered that question previously. If that patient has a previously scheduled appointment, or this is part of your ongoing follow-up with that patient, absolutely, then you can reach out to them to either reschedule for a virtual appointment or schedule a virtual appointment that you would normally have scheduled for an in-person appointment. If you're getting referrals, you're in a consulting practice, you're getting referrals from other physicians, then it's absolutely appropriate for you to contact the patient to set up an appropriate time for that consultation with them.
Great, thanks, Norma. And I see by our time we're now at time. So again, I want to reiterate that the questions that we haven't been able to answer either live with our subject matter experts, we will take those offline and post them to the website. I also wanted to acknowledge that we're working with the Alberta College of Family Physicians to provide CME credits for tonight's participants. And in closing, I would like to extend our sincere thanks to our physician members for participating in this webinar, and our panelists, Dr. Brad Baylor, Dr. Heidi Fell, and Ms. Norma Shipley. A special thank you to the AMA Board of Directors for supporting this work. Stay safe and healthy, everyone. Goodbye.